No, good afternoon, everyone. Welcome. I am Jae-young Park, one of the moderator of this panel, Corruption in Healthcare, the Silent Threat to Global Health. It's an honor to have such a distinguished panel of experts here today to discuss a critical issue affecting global health. Corruption in healthcare is a multifaceted problem that impacts patient care. Today, we have distinguished experts. First, let me introduce them. Dr. Eung-han Kim, with his esteemed background in medicine, specifically pediatric cardiac surgery, and his contribution in global surgery at the Seoul National University College of Medicine and the J.W. Lee Center for Global Medicine, brings a wealth of knowledge and insight into the complexities of healthcare systems and the challenges posed by corruption in global health. Ms. Hae-jin Jung, from the Korean Foundation for International Healthcare, offers a unique perspectives of international cooperation and development aid in terms of political instability, enhancing transparency, and building resilient health system. Dr. Nariman Islamov, a cardiac surgeon from Uzbekistan, will present the preliminary outcomes of our research on current studies on corruption and global health. He will also reflect on his firsthand experience of the effects of corruption on patient care and the ethical dilemmas faced by healthcare providers in regions where corruption is prevalent. Lastly, Dr. Suji Choi from the New York University Grossman School of Medicine contributes with a strong academic and research background, focusing on systemic issues that enables corruption and the potential strategies that can mitigate its impact on health systems. As we delve into today's discussion, we look forward to hear their insights, experiences, and recommendations on addressing corruption in healthcare. With that, I will turn it over to Dr. Kim.
Good afternoon. I'm Eung-han Kim from South Korea. My topic is corruption and global health. I'm director of J.W. Center for Global Medicine of Seoul National University. J.W. Lee is the initial of Jong-wook Lee, who is the 6th Secretary General of WHO. The mission of J.W. Center for Global Medicine is building sustainable healthcare in underserved countries, an integrated approach through education, research, and global outreach. Recently, J.W. Center for Global Medicine published several articles. The content of the article is evaluation of 10-year experience of team-based global surgery program in Mongolia, quantitative research of global cardiac surgery program of Ethiopia, education program for decreased maternal mortality in Nepal, review article of global surgery, evaluation of 10-year team-based capacity building cardiac surgery program in Uzbekistan, impact of global cardiac surgery program on global health in Tashkent, and we participate as a course of a textbook for global cardiac surgery, which was published at Harvard University. During past 20 years, I did global cardiac surgery program in Asia and Africa, which was include China, Laos, Vietnam, Mongolia, Uzbekistan, Nepal, Ethiopia, and Cote d'Ivoire. Cardiac surgery was one of the national agenda of Ethiopia, so I started global cardiac surgery program from 2015 in Ethiopia. At that time, there was no cardiac surgery program in Ethiopia. And for cardiac surgery, there need more than 300 items, which include surgical instrument, drug, surgical machine, and the consumable material and diverse fluid solution. And nothing was available at that time. So as you see in this slide, I have to transfer 315 items for cardiac surgery. As you expected, we have to do very complex processing for passing through customs. And at 2015, I did 10 cardiac surgery successfully, and I started capacity building education program at Addis Ababa University Black Lion Hospital continuously. The cardiac team of Ethiopia did every effort for success. After 5 years, the cardiac team of Ethiopia uploaded one photo in Twitter. The first open heart surgery with a full Ethiopian cardiac team of Black Lion Hospital. When I visited the Dulikhel Hospital of Kathmandu University in Nepal, they want to do cardiac surgery. So I started cardiac surgery capacity building education program for cardiac team include cardiac surgeon, cardiologist, anesthesiologist, perfusionist, and nurse of ICU and operating room. 3 years later, they sent me one photo of a cardiac operation by Nepalese. I believe the great power of education. Corruption can be defined as abuse of entrusted power for private gains. For me, corruption was most difficult problem which cannot overcome during past 20 years. Despite being one of the most important barriers to implementing universal health coverage around the world, corruption is rarely openly discussed. I am also outlined the people's fears around the topic, which is needed to address corruption, and the responsibilities of the academic and the research communities in all countries, irrespective of their level of economic development. If we are really aiming to achieve the sustainable development goals and ensure health lives for all, corruption in global health must no longer be an open secret, because corruption is the biggest threat for the future of health globally. Corruption is an open secret known around the world that is systemic and spreading. As you see in these figures, the health sector is an attractive sector for corruption. In our global world, we have to recognize the role of developed countries as the supply side of corruption equation in developing countries. We also have to recognize the existence of corrupted and corruptors, and the need to work together in the quest for a solution for this global problem. With more money, there is more corruption. The availability of foreign aid for health also fueled corruption globally. Over 2/3 of countries are considered endemically corrupt, according to Transparency International. The corruption perception index is currently lower than 50 in 91% of African countries. Additionally, the score is below 15 in 89% of other low and middle income countries worldwide. Corruption affects the poor and the most vulnerable. And the corruption in the health sector is more dangerous than in any other sector because it is literally deadly. So corruption violates the rights of individuals and the communities. When corruption related to health and health system, individuals and health outcome are deadly affected. It is estimated that each year corruption takes the lives of at least 140,000 children. It is 1.6% of annual deaths in the children under 5 years old. As seen in this slide, child mortality is higher according to the severity of corruption perception index score. In societies with less adherence to the rule of law, less transparency, and less accountability mechanism, health systems are more corrupt. Corruption threatens any effort to reform the public sector and to reach universal health coverage, which also affects the effort to achieve the UN's Sustainable Development Goal 3, global health and well-being. Corruption also causes demotivation and burnout of human resources. So someone said, it is the cancer of our health system. According to the data of 2019, it is estimated that the world spent more than $7 trillion on health service, and that at least 10 to 25% of global spending is lost direct through corruption, representing hundreds of billions of dollars are lost each year. These billions lost to corruption exceed WHO's estimate of amount needed annually to fill the gap in assuring universal health coverage globally by 2030. However, the true cost of corruption for people is impossible to quantify because it is mean the difference between wellness and illness and life and death. Anyway, corruption is embedded and systemic in the health sector. Corruption has been overlooked or ignored because it is not always clearly defined and has been seen as a way to make a dysfunctional system works. A corrupt act is more likely to happen if the perceived benefit is higher than the sum of the psychological cost, the perceived probability of criminal cost, and the social cost to the individual, and the cost of doing the corruption act. Corruption in global health should not continue as an open secret. It has to be confronted and brought to light. Good governance is a crucial factor for well-functioning health system and for better health outcomes. Some experts suggest that there are three key factors that increase opportunity to engage in corruption practice. First, being in a position of power in a system with inadequate oversight provides an opportunity to abuse. Second, financial, peer, and personal pressures. And third, a culture that accepts corruption. According to the issue, could be a way of approaching anti-corruption measures, strengthening accountability, improving data, improving supervision, improving salary, provided incentive to reward good performance and sanction for poor performance, increasing transparency, and providing a platform for citizen voice and law enforcement are all measures that has been suggested. There are so many suggestions for strategy to confront corruption. However, evidence for the effectiveness of these suggestions is still scarce. Funding for the research on intervention against corruption is still very scarce in the world. All countries, irrespective of their level of economic development, should be equally committed to helping ensure that in our world, corruption in health will be eliminated in the same way that was achieved commitment for the elimination of disease. I am hoping that in coming years, if interventions are tested against corruption in the health sector soon, we will have effective anti-corruption models that could truly accelerate improvement in the global health. I think that include me. Everyone who are in here had experienced the big trauma-related corruption during international public health activity. In this session, I want to hear your experience-related corruption. Open talking about corruption will be a starting point to find the answer and action. Thank you for your attention.
Thank you, Dr. Kim, for sharing your insights. Now let's hear from our panelist, Ms. Haejin Jung. Could you please share with us your perspective and experiences in transparency and global health in terms of development aid?
Good afternoon, everybody. My name is Haejin Jung, as Park introduced, and I'm the director of Dr. Lee Jong-uk School at Korea Foundation for International Healthcare. It's a government agency providing governmental level healthcare aid to developing countries. And then we are operating a global healthcare capacity building program called Dr. Lee Jong-uk Fellowship Program. And the theme of this session is quite sensitive and controversial, but we cannot neglect that exists. So let me share some of my experiences, and we can freely talk about how to prevent and overcome at the end of the session. There are many stakeholders in healthcare ODA. When developing a cooperation project together, we need to consider all the stakeholders' needs, wants, and priorities, and make a consensus to increase the effectiveness of the project. And development agencies such as COFI, us, design interventions considering what the effectiveness and impact will bring, the project will bring, as well as global health trends. And when selecting areas of interventions, the most important consideration should be what the recipient country, the partner, needs. Depending on the country's healthcare status, gaps, and policy priorities, as well as the relevant to that. And second consideration will be what the donor country can offer. So as well as partnership strategy of each country. And oftentimes, we don't talk about it, but we have to think about mutual benefit. Not on the surface, because it could create some ethical considerations, such as conflict of interest. So while carrying out cooperation activities, I have had many great experiences working with partner countries and met wonderful partners, but faced various obstacles because of the external threats that we cannot control, which badly affect the global health outcomes, such as political instability and cultural conflicts, natural disasters, and war, both domestic and international. And everybody knows about pandemic, because we're hit by it currently. And let's talk about political instability today. So we will focus on the political instability side. It happens not only on the recipient side, but on both sides. Development means change from the existing status, but the current group in power does not want to change anything because they are comfortable there, right? So their resistance or even counteract towards cooperation activities seriously hinder the outcome of the activities. And then assigning proper people in proper places is very important. But nepotism, factionalism, and favoritism is all there. So lining up, I would say it's lining up. And also bureaucracy is everywhere. I, as a government worker, I face reportings of reportings for reportings all the time before doing the actual work. So that's a bureaucracy. So international works involve more approvals and signatories. So like shipping and handling and officer signatories getting to get the approvals and customs clearance, etc. And lastly, the more serious problem is the embezzlement, moral hazard of using public goods as your own creates a big resource drainage. So now let me share some of the experiences regarding that. Development often requires breakthrough of existing ideas, like I said before. When we partnered with country A, researcher from a public institution conducted a joint research with us. And the result was published in an internationally acclaimed paper. So the researcher was invited to international conferences like this as a panel and a speaker. Senior members of the institution did not like it. So they ended up seconding him to an affiliated institution, which has no relation with his research area. He was the focal point of our cooperation, so the project implementation was badly affected by the sudden change of the personnel. And he couldn't continue on applying the research findings to the national policy. So it was a big loss. So let's move on to the second case. So excluding from the main job. So Kofi invited to implement advanced surgical procedures in country B. Kofi invited a team of young surgeons from a national hospital under the Dr. Lee Jong-woo Fellowship Program. So when the team finished training and went back to their original hospital, senior doctors of the hospital did not allow them to practice what they've learned, making it difficult to apply the team approach in their own institution. So some members of the team ended up leaving the hospital, causing brain drain of the trained personnel with our taxpayers' money. And they originally had a goal to improve the inefficient surgical procedures in their own institution and save more lives. But now they cannot work as a team anymore since they are all spread out in private hospitals. And a frequent leadership change. That happens in my country as well. And a human resource strengthening program, when we are doing it, carrying it out for a long period of time, it is common for various unexpected situations happen that have a negative impact. And a change in leadership is likely to be one of them. Okay. So a human resource strengthening project was carried out at a national hospital in country C. And during the project, the Minister of Health and the hospital director were replaced twice. The replaced hospital director requested a significant revision of the original plan, so the project was delayed. And the workload increased due to the master plan change and reapproval process, and the reorganization of participating trainees. So in the final year, the hospital director was replaced again. He did not favor employees with better capacities and close relationship with previous former director, so causing them to resign, and resulting in a significant blow to the sustainability of the project effectiveness. However, unlike natural disasters, it is believed that negative impact by sudden changes in the leadership of the ministries and partner organizations can be minimized to some extent by communicating with partners in advance to ensure sustainability of the content and effectiveness of the project. And I experienced these cases, I think more than once a year, shipping and handling fraud. To improve sanitation in a public hospital in country D, we procured commercial scale washers and dryers and supported them. And since country D is landlocked, the shipment arrived in a neighboring country B, this port. So we contracted a door-to-door shipping with shipping company A. And shipping company A, instead of delivering it door-to-door, they handed the freight to another shipping company B at the border without paying, and asking them to collect money from the recipient side. So the shipment delayed 6 months, and the company B insisted getting paid from us, so we had to pay twice the shipping cost. During that time, I was pregnant with my second child, and then I couldn't sleep at all until it was solved. It was very important for me. And then we ended up getting the money back from the company A, which is a very rare case. But I had to use all my known networks to track them down, and even stalking the owner of the company A, the shipping company, and then asking where he is and where the money went. And then we finally got the money back 6 months later, and then asked them for not complying the contract term door to door. And it was very stressful. And another case is about customs clearance. While I was serving as a representative in one country, COVID-19 pandemic occurred, and donors made a joint effort to support the pandemic in the country, overcome the pandemic in the country. And the vaccines and PCR test kits have arrived in the country. And since those were very time-sensitive and emergency relief materials, special approvals were granted to waive the customs duty with a letter from the minister. However, National Security and Ministry of Finance, together with brokers handling the clearance, did not cooperate well, causing time-sensitive supplies get obsolete by the time those were cleared. And it costed extra money and lives of infected people. Customs clearance is another challenge when carrying out international support projects. Various ministries, government agencies with different interests are involved in the process, making it complicated. So in 2022, we received an award from the minister for helping the country during COVID-19. However, it would have been much easier if the customs clearance was transparent and straightforward. So lastly, let me talk about embezzlement. Upon completion of our fellowship program, COFI supports items to apply the fellows' knowledge back in their own countries. Usually portable ultrasound, smart tabs, and the patient monitors, etc., are given to the fellows with the condition to use the items only at their work, which are public institutions. So when we visit for follow-up support and on-site consultations, we always provide on-site consultations about within 6 months of their graduation. Some fellows use the items at home or in their own private clinics, making extra money with publicly donated items. Furthermore, they ask for consultations on cases they work on private clinic patients. So we ended up changing our policies. Rather than giving the items to the individuals directly, COFI now donates to public institutions where they belong to, with an official letter requesting receipt letter with installed photos from the directors of the institutions. So this kind of micromanaging discourages partners' ownership and very bureaucratic itself. But few bad cases make all the good people suffer. So what will be the ways to overcome the political threats? I was just thinking about it, but there's no answer, so we can openly talk about it later on. First, understanding the culture. So we cannot call it corruption yet until we know the background, right? We have, like I said on the first slide, we all have different priorities and speed of work, but we cannot call it corrupted. And then, Western value of utilitarianism and the Eastern value of pluralism always conflict. So it might be the way of getting things done differently. And when carrying out the projects together, we have to do needs assessment together. If the needs are found by one side, the other side receiving it might reject it. So we cannot call it a corruption. So we can do the pre-assessment of needs, both institutional and national level together from the beginning. And then we can make I'm talking about the capacity building project, like fellowship projects. We can do the long-term capacity building together, plan together. That way, every year we know what is expected. And then after the project is done, it's not the end. So we will do the follow-up support to see if it's well applied in their field by doing on-site consultations and teleconferences. And then we can even support scale up of their own action plan to bilateral projects and policy implementations. That way, they are more motivated to contribute to their own society. Okay, so I will open the mic at the end of the session to get more suggestions. Thank you very much.
Thank you, Ms. Jung, for your valuable insights. Now, turning to our next panelist, Dr. Nariman Islamov. Dr. Nariman, could you please share preliminary results of our research and your thoughts on corruption in global health?
Good afternoon, everyone. I am Nariman Islamov, a pediatric cardiac surgeon from Uzbekistan. Thank you for Lee Jong-wook Center for organizing this important panel. Today, we will share insights from our scoping review on corruption in low and middle income countries during COVID-19. The developing countries faces challenges in the healthcare. The challenges are compounded by the pre-existing corruption. The COVID-19 pandemic exposed the weakness and highlights the impact of corruption. To improve the healthcare outcomes and build resilience in developing countries, accessing these issues is important. So our research question is, how did low and middle income countries address corruption in healthcare during the COVID-19 pandemic? Our study design involves conducting a scoping review to explore anti-corruption strategies in healthcare, particularly during COVID-19 pandemic. We utilized the PubMed database as our database and employed the key terms such as intervention, corruption, health, and COVID-19. In terms of data analysis, we use the deductive approach to identifying the recurrent themes. Our review process depicted in this prisma flow diagram resulted in 13 studies included in our analysis. We have identified that eight studies where the primary outcome is directly related to the corruption. Among among them the 6 studies is specific country or multiple country, while 2 studies examine the corruption in the international level. 5 studies investigated corruption as a primary explanatory variable. In terms of research type, we found that 3 quantitative and 5 qualitative and 5 the mixed method studies. And today we will focus on studies where the primary outcomes is directly related to the corruption. The study map shows the included studies were mostly conducted with Africa. Our findings highlight the several corruption risks, like from the data integrity, data nepotism to important informal payments. The most cited barriers were cultural acceptance of corruption and the lack of trust for public authorities. These challenges underscore the complexity of combating corruption in healthcare system. Successful strategies against the corruption include the rigorous tracking, management supervision, non-government organization support, and World Health Organization's good governance management programs. And the low and middle income countries have employed various strategies to combat, but they face ongoing challenges such as cultural acceptance of the corruption and the lack of public trust. Corruption extends beyond individuals' actions. It's also rooted at institutional and systemic level. Nepotism and favoritism is a prevalent form of corruption in the many low and middle income countries, especially in post-Soviet Union countries. In this section, I want to say that we have personally experienced these both individual actions and institutional and systemic actions in our experiences. During our experience, from the early stage of our program is starting, when the young surgeons coming back from abroad and they started their work, the main role plays the chief of department, senior surgeons, who didn't allow and never allow them to do the surgery, and they always cut them the way. And slowly, when they start the surgery, they didn't allow them to do the complex cases. And second is systemic and institutional level is when the director of hospital was changed. He bring his own staff, and he looking the ways to make money, and they implement their own rules and they strictly follow these rules, and they fired everybody who didn't follow these rules. And they started to make money from the pharmacy and foundations and even the physician's salary by decreasing this salary. And this also shows that despite the various strategies, the healthcare has a lack strategy to control corruption. More quantitative studies needed to transparency, accountability, and to measure the corruption level. Our study's limitations includes its focus on the COVID-19 period for potential publications bias and the variable quality of study. These factors may affect the generalizability of our findings. In conclusion, it would allow to our. In conclusion, future studies should focus on considering about the corruption index in the healthcare matrix on institutional and systemic level. These studies should strengthen of mutual accountability among countries and healthcare system. Thank you for attention. I would like forward to the discussing these findings further and exploring collective efforts to the trackle contribution in the global healthcare. Thank you.
Thank you, Dr. Nariman, for your valuable insights into the corruption in global health. Now let's hear from our last panelist, Dr. Suji Choi. We are eager to hear from your perspective on future direction of anti-corruption in healthcare.
Hi everyone, thank you for sticking around. It's been a long day and it's beautiful outside. But I do think, hopefully we'll have a chance to have a lively discussion at the end. So I'm Suji. I'm an assistant professor at Department of Population Health at NYU. And full disclosure, I am an alumni of the J.W. Lee Center, where I spent my pre-doctoral days. So, that's kind of my conflict of interest there. But first, I wanted to also thank our team in kind of putting the panel together and also the research forward from the J.W. Lee Center as well as NYU, and also some of the interns who've been part of the work. So by now you've heard about different bits and pieces of corruption and how it's not just affecting legal or ethical and has ethical concerns, but also how it impacts people's lives and people's health and the health system in general, and how it may also disproportionately affect the low and middle income countries. And often, corruption, I think it's really hard to define and understand and even try to solve because it involves, multi-systems, multi-level actors, as well as multi-sectoral actors, and sometimes kind of expands beyond the healthcare sector. So in this presentation, we're doing something more exploratory. So we're trying to understand if there are different ways to use, prior frameworks to understand and try to begin to put more action towards doing anti-corruption intervention work. So just to briefly do a quick review, so there are multiple ways of intervening for corruption activities, and they generally tend to fall under a couple of these umbrellas. So either you're strengthening your accountability or detection and enforcement within the country, or you're increasing transparency. We've heard a lot about that. There has been a lot of push towards media campaigns. There's a lot of acts towards disclosing financial relationships and conflict of interest. And also there's a prevention effort as well going on, trying to kind of target the health system broadly, and either you're kind of trying to improve the healthcare system by providing more incentives for what's called clean behavior, or you're trying to boost the income of the healthcare workers in the countries to prevent embezzlement, for example. And there's also a lot of efforts that are being done at the international organization to country level, right? So we've heard about a lot of frameworks that WHO puts together, the United Nations Office on Drugs and Crime has put together. And they also fall under similar umbrellas. So doing preventive measures, fostering international cooperation. There's also a big push towards criminalization and law enforcement as well. And you can kind of see the recurring themes here as well. And another example of this is international organization to multi-country frameworks. So this is being done at the regional level. Also similar themes, a lot of monitoring and evaluation, transparency work, sharing the vision, and a lot of the frameworks are kind of being set at the strategic planning phase, where a lot of countries, higher ups, a lot of the approach tends to be top down. But kind of bringing the regions together to kind of foster collaboration and maybe some accountability, and maybe they are sharing, similar challenges in their countries. And the list goes on. So when we were doing the gray literature review, during the scoping review, we found tons of frameworks, and each agency seems to have their own. And as mentioned, the themes are pretty similar. But just wanted to highlight that it's been, there are numerous frameworks and everyone's really interested and invested, but it seems to be, very difficult to overcome. One thing that I did want to highlight was that even though, there has been a lot of work in the similar areas, I think there was a focus towards moving away from punitive approaches in more of the recent talks. So we kind of there are a lot of talks and energies around really focusing on team-based approaches, rigorous tracking, what's called joint supervision or having mentors. There's a lot of work towards providing technical assistance at the international organizational levels, and also having some sort of peer networks where they're trying to solve problems together. But still, one of the things that we wanted to bring up and try to explore was this idea that they seem to be very high level. So as an individual, when you confront some of the challenges, right? Where are your go-to sources, or how do you kind of begin to try to intervene in just the prior slides. Dr. Kim showed the same slide, but trying to intervene in these multi-level prongs in order to prevent corruption activities. So we looked into the literature of organizational psychology, and in the healthcare management literature, and so this work also goes back a long time. But there's this idea of trying to unpack what the resistance to change is in the organizational psychology literature. So Cotter and Schlesinger from 1979, and also there was a derivative work done by Warwick recently, kind of try to unpack why people are resisting to change. So for example, when we're trying to promote anti-corruption activities, what are people thinking, right? So it's trying to kind of foresee what the resistance may be and trying to intervene at the individual level and also at the organizational level. So Cotter and Schlesinger really focuses on the journey that one person may kind of go through as they are kind of struck with the potential external change. And also trying to actually promote what's called change agents. And I think in the implementation science work, there's also a lot of talks around, champions, individual champions. So it's kind of similar idea, training cadre of folks who can really be at the forefront of the change. So, and these are some of the themes that are intervention strategies that are identified in the Cotter and Schlesinger literature as well as the Warwick literature. So it's trying to understand why people may resist change when there is an anti-corruption framework being imposed on them. So, and actually the numbers in these circles represent how many of our articles in our scoping review mention these. So trying to see if, which ones are being mentioned more in the literature currently, and trying to see where the needs may be. And the most cited ones that we've seen are the lack of trust. 10 out of 13 articles mentioned it, lack of awareness and understanding, and also the economic interests, cultural and normative factors. I think most of these came up during the 3 presentations ahead of me. And so what, right? So what they do that I think is pretty unique is they actually come up with how to act after they kind of confront some of these resistance in their organizations and the individuals. So the Concurrent Center really focuses on like education, participation, facilitation, negotiation, and coercion. And I think people are really, moving away from the coercion boxes down here. But they really map nicely all these methods to how to use them, when to use them, and what are some of the advantages and drawbacks that may be. So we're hoping that we can use some of these elements here and tailor them to the countries of needs based on our projects, and try to see if we can test out some of these resistance to change interventions. And also, this is a long list of strategies, but this is the more recently work that's more inclusive of the Cotter slide that was presented in the right before this. So it actually, maybe this is too much detail to go through. But if you're really interested in the literature, I highly suggest looking up these 2 articles and kind of see how they are kind of confronting these resistance to change in individuals and at the organizational level. And so finally, I think, so we're hoping that applying some of these frameworks and the strategies will be helpful in forming something more practical in our projects, and as we kind of try to test the effectiveness of some of these behavioral interventions. And I think just providing resources to countries that can be practically used in their settings is really important. So we're considering different practice recommendations of defining target populations, and and also probably the change agents, and also the thinking about how to collect data. I think that's also been we've been talking about how it's really hard to measure a lot of these things, and we're now trying to get into the talks about how to measure these at the national level, at the organizational level, and whether the mode may be the survey, interviews, or different types of checklists or stakeholder meetings, and hopefully all of these things will lead to intervention development and potential monitoring and evaluation after it's been rolled out. So that wraps up my presentation. I'm looking forward to the discussion, and thank you for sticking around.
Thank you to all our panelists for your insightful contribution. Now, I'd like to open the floor to our audience for additional perspectives on the topics of corruption and global health. Anyone who likes to openly talk about the topic, please come up to the floor. Thank you.
Whoops, I didn't want it to go all the way down. Hi, I'm Maggie McDonald from the University of Pittsburgh. And Dr. Islamov, as I was listening to your talk, one obvious issue was front and center for me, and that is that with some of our partner countries, we do not speak their language. So there's that which happens in English and that which happens in the language of the country. I know in our case, we've worked in a neighboring country, the Republic of Kazakhstan, and helped a new university, Nazarbayev University, start a medical school from the ground up. The university itself was opened in 2010. We started planning the medical school in 2012. And one of the big concerns was the integrity of the admissions process. And what we did with that was to have some clear quantitative indicators like MCAT scores. And I will say that faculty and staff of the medical school were approached about, hey, how do I get my kid into the new school? And we just had really clear, transparent criteria that had several quantitative items that were really hard to tamper with. So a comment, and I don't know, that should lead to a question. I'm sorry, I don't have a question at the end, but I'd like your thoughts on the issue of language.
I don't think he has comments at this point, but because it wasn't a question, so I think he's having he's wrapping his head around the comment right now. But yeah, I think we see language and also cultural humility as one of the key factors in addressing some of these challenges. And it's really hard because it's not just the language too, and there's a lot of talks around using technology to overcome language barriers, but I think there's more to that than just the language. So yeah, I mean, it's a lot of the Asian countries are very keen on education, and they're so I could definitely imagine all the parents being very excited about the opportunity. But I do think the language and also probably the culture of just education will play into it as well. Yeah.
안녕하세요. Hi, my name's Sunyu Cotter. I'm a daughter of Korean immigrants born and raised in the Bay Area. And I was a Peace Corps volunteer in Uzbekistan. So to you, Doctor, Assalamu alaikum. Tanishkan Namdan Judahur Sanman. Thank you so much for this talk. I actually find it particularly brave and courageous that that you're all working on this topic. I am the Deputy Director for the University of California Global Health Institute. I'm going to share my business cards with you. I brought many, but we are dedicated to cultivating the next generation of global health leaders. This area in corruption is an area that we're actually not currently focusing on, but I would love your thoughts on maybe any nuggets of wisdom or advice for global health learners who might be interested in tackling this in a very, very complex landscape. Or any success stories?
There is a diverse type of corruption. There is an article, the corruption is a culture. So partially I accept it, because it is not always guilty. So we have to be, so during this presentation, there are many words of trust each other. Trust building is not easy. Take times. So when I started the project of this global surgery program, I was always thinking 10 years. So it need time to building trust. The simple understanding is very easy to the brain, but heart is not ready. Just I take time. For example, I'm working in global surgery program, so we're talking about that the salary of a doctor of middle and low countries, the salary is very low. The monthly salary is 200 to 300 US dollar. They cannot survive. So when I visited and done project, the afternoon, there's no doctor in hospital. Afternoon, just our team running the operation. So nothing to do. So we counterpart is usually national hospital or public hospital, especially in public and national hospital salary is very low. Nothing to do. So even I excuse, they go second job. And that situation, very difficult to sustain a program. So we have to do understanding and building trust is not easy. Take time and slow. It is a systemic. There is a systemic. So we have to understanding is needed. So diverse type of system. It is everything is there is in aspect of high developed country. Everything is a corruption, but not all corruption. It is a culture. So you have to understanding.
Hi, good evening. Thank you for your presentation. I was wondering your thoughts on what is our duty as providers or as global health partners, when we witness acts of corruption. So it happens that if you work at an NGO or you're part of a partner initiative and you witness or you find yourself within events that are clearly corruption. So is it our duty to report said events and potentially bring backlash and whatever consequences that might entail for our operations? Or should we turn a little bit of a blind eye as to not compromise operations and maybe be initially complicit and try and strengthen systems in another way or find ways that are not punitive or confrontational? Thank you.
For successful ODA project program, usually the official government side, they recommend the reliable partner. That means the government is usually changing. Government changing, everything changing. So in aspect of donor side, they usually recommend NGO. NGO is a little change. But in my aspect, I wanted to building only public health sector strengthening is, I think it is important. Private sector is very difficult. The purpose for me, for global surgery program is anyway, capacity building in public sector and education sector. That is only, I think, it is sustainable. But in real aspect, it is not easy. And public hospital is change is very difficult, very slow change. So changing, I want to change, but change is very difficult. So there is a gap. So it is a case by case. But anyway, so it is very difficult. But in donor side, I had some government side. In government side, it is they wanted to very regulation, strict regulation. But it is a case by case. So I want to say again, building trust, it takes time. So understand the cultural difference. So there is for ODA, successful ODA project usually had a period very long. And the building trust take time, and so some government side, they wanted to very short effect, but in ODA project, that should be long. So building trust is take time, and the cultural difference, how we can decrease the cultural difference, and how we can decrease the gap between the donor and recipient side. That is a big issue. So at this time, I wanted to your experiments. Everybody talking about the your experiment, that may be helpful to understanding the added situation of recipient side and donor side.
Let me share one of my experiences regarding the last question. I've witnessed a lot of personal level corruptions. And then if that person is very important in that society, oftentimes that's the case. And he thinks he has a right to do such things. And then if just talking through and then understanding the situation, understanding the culture of each other, that can solve the problems, I will talk through it to the person, the direct person directly. But if the situation doesn't get better, as a government organization, we have a duty to report, right? So, but I'm not gonna report in detail, but I will just write very politely. So because of the certain circumstances, it will be difficult to continue on this project with this division. I'm not gonna say him directly, but his division. And then, I will ask the government to change the partner. But it's when we have to burn the bridges, It's up till that level, I will try to work through it and then discuss and try to solve and communicate. So it's not easy. Yeah, thank you.
Hi, Nick Bass from East London, UK. Most of my work is with colleagues in Africa and South Asia. And you were asking earlier for examples of ideas and ways of addressing problems. We've heard a lot about problems. I salute the work that you've all done, as one of the previous colleagues mentioned, and I think that's very brave, and this is a really, really difficult topic. But first of all, just to mention there is a particular vulnerability point that makes the risk of corruption even more, and that is when emergencies occur, such as we've had in recent years with the pandemic, but also in refugee settings, conflicts, etc. Money comes in very rapidly from donors, whether it be governments or charities, etc., and sudden surges of money that need to be urgently delivered are also represent an opportunity for rapid corruption as well. And I can assure you that it's not just low-income countries that are vulnerable to this. This happens in high-income countries as well. In the UK, for instance, we've been undergoing a multi-million-pound inquiry into what our government was doing during the COVID pandemic, issuing contracts for PPE, for instance, to all their friends and families. And minister after minister has come back with the excuse that, it was an emergency, we need to do something quickly. Hence, all their friends and family got the lucrative contracts. But that aside, in other settings across the world, all sorts of disasters, conflicts, famines, etc., occur, and money comes in. There were examples during the pandemic of government ministers from Africa being caught on camera laughing when they were finding an opportunity to personally bank large quantities of cash from COVID payments. But now let me give you a good example of something that was effective. A lot of my work is with Uganda, and Uganda hosts the world's third largest refugee community in a very small and low-income country. And a couple of years ago, there was an issue with high-level ranking officials who had put in false accounting figures to get more funding from UNHCR and overinflating the number of refugees coming in. This was discovered and very rapidly acted upon by the Ugandan government to their credit. And this can happen if there is that political will. At a lower level, but a much more common level, when drug distribution and etc. is problematic in many low-income countries, and often officials, or even, I'm sad to say, senior health staff, might be complicit in commandeering some of those drugs and then helping to resell them in private settings. There are ways that sometimes this can be counteracted with use of community panels, of council panels, who can form an independent layer of accounting for and to check what's happening to the money and the resources as well. And they can help to uncover and bring officials and senior health people, etc., to account for exactly these things and ask them where is the money, where are the drugs disappearing to? And so that might be a way that even low-income countries can seek to counteract. And again, it seems to work in varying degrees in a number of low-income countries. So it's not all bad news. There are good examples of effective ways of dealing with this. And I also just wanted to re-emphasize that it's not just low-income countries. I can assure you rich countries are frequently complicit in this stuff and have their own problems as well.
Okay, hi, my name is Laura. I'm from Peru. I'm from Cayetano Heredia's Peruvian University. And let me tell you a little bit of my story and also part of our research results. I hope to not put you into troubles after this, but we did a research study about public institutions and informal payments in Peru based on a national-wide instrument, because as part of the government's initiative to measure corruption and be able to do something about it, they added a model on corruption and governance. The results taught us that less than 0.5% of the population had made informal payments in the last 12 months. A total success. I mean, in Peru, corruption is no more a problem. Of course, many theories about lack of knowledge, lack of confidence to report the actual frequency, among other theories, appear and are discussed in an already published article. But the real question is, what are the challenges and how can government institutions, which in some countries have lost the trust of the population, could begin to implement initiatives that seek to reduce corruption in healthcare? I know that as academicians, maybe it's kind of difficult to start thinking about initiative or how can we do it, but that's the gap that we need to address in some point in order to do something for reduce corruption in healthcare. So, thank you.
Dr. Nariman, and he is working in Uzbekistan. I know him more than 15 years. Still, I'm going the program. So initiation, when he was 15 years, he was very young, a young surgeon. At that time, I recruited him as a cardiac surgeon. So he very hardworking. And after 10 years later, 10 years program, he established a cardiac center, National Children's Hospital. he did more than an annual case of congenital heart surgery, 1,500 cases. It is the most big pediatric cardiac center in Middle Asia. So I was very happy, successful. But this successful program is change of Minister of Health, director change, and hospital change, all destroyed. Number one pediatric cardiac center in Middle Asia is suddenly disappeared. It is very painful for me. And also, I think he is more painful, but the team, our education team is still functioning. Some separate. But I think with education, sometimes there is a chance again. We recruit the best members again. So in that situation, everybody working in international public health is very frustrated and disappointed. But by some project, there is still their percentage in their country. So sometimes I think there is a chance again. So we have a persistent support. So in donor side, and government is impossible, but in donor side there is a long term. Think of the long term and the persistent encourage and pursuit and never give up. So that is very important in donor side. Not easy. So, but we had a international building such a system. So sometimes, if we had some project is initiated, sometimes that person will be activation. So whenever I did a project, sometimes I'm sometimes waiting. Initiation, waiting, they take time. Not easy in that situation. But if you started the program, sometimes they will activation. For that, we continuous contact, keep in touch, and continuous support is needed. Such a system is, I think, needed. So that is only not easy in government side, especially in government side. But who will continue? Such an organization should be. We have to strengthen the power and more activation. Such an international teamwork.
Let me add on to Dr. Kim's comment. Change from outside has limitations. So the most important thing is capacity building of right-minded people within the country. That way they can be motivated to make changes from inside. And then they can peer review their colleagues and then keep them more clean and transparent. So I think that's the almost only way to go about it. Thank you.
I have a question. Thank you so much for this talk. My name's Emily Glenn. I'm at the University of Washington in Seattle. And sort of related to what you had just mentioned, do you see any role as someone who provides ODA, like a role for aid, using aid as leverage for increasing capacity for things like citizens' voice or enhancing, mechanisms for enhancing transparency? Like how can we, because there's so much aid in global health, like is there a way to leverage that aid to make long-term changes? More in-country changes, like you had mentioned having people being more accountable for what they were doing with the devices, but is there a way to look more broadly to build sort of clean capacity, human resource capacity, and citizens' voice in these areas? Thanks.
Thank you. So we have about 1,500 fellows in like 30 countries from our program, and we have alumni associations there. So they become kind of like advocates of contributing what they've learned back to their own societies instead of for their own good, So they're kind of making a network of people and supporting them to contribute is a way of doing that, I think. And then also, as you said, citizenship, and those kind of things, not only the skills, clinical skills itself for medical personnel, how the Dr. Lee Jong-wook tried to make the changes in the global health, and all those things are included in the curriculum. That way they can also have the same kind of mind to contribute back to the global health society. So I think that could work. And then this is apart from my fellowship program operation experience, I was also serving in a country as a director, a representative of my organization. And then back then, development partners in health sector jointly had a meeting every week, and then we had a big meeting every month, and then we had a sectorial meeting every week. And then we, instead of doing individual work per each donor, we kind of made a harmonized list of things to do. That way it doesn't create overlapping support towards one country. So I think that's also harmonization among the donors is also another way of reducing the corruption. Thank you.
Are there, oh, okay.
Sorry, it's out of time. My name is Yang Huang, and I'm from NYU School of Medicine. And I think I really enjoyed this talk, and I'm just going to share some of my experience. I think treating corruption as kind of like thinking about capacity building, I feel like using organization kind of approach, this sounds like a right direction. And so in our work in global health, like capacity building, I think there's also a shift to think about how to partner with high level. And I think education, the approach that you have been doing, it seems like it's a good solution, because in a lot of our capacity building efforts also trying to think about how to changing the culture from the top level. And I think you have a good network, like your fellowship, it could be a good network, and to think more about how to leverage that, partner with high level to change that. And we see some of the example, like successful example, to make it to the policy level and to see that culture change. One other thing I learned is also like cross-country kind of partnership to create those kind of pressure for government to see what's the right partnership from other countries' experience. And I think accountability you talk about, that also like seems like very effective. It's like when multiple countries working together, government stakeholder, and they see other country like making promise and making some progress, and it's also like kind of like peer pressure to make them move into the right direction. And I agree, it takes time. And sometimes we all have issue around those kind of partnership. But I think the framework that you're proposing, kind of thinking about organization and how to using more positive way to create culture, that feels like, seems like it's in the right direction. So thank you for those words.
So are there any other comments from the floor?
My project is always concerning of the human resource, education of human resource. That is the most difficult, and sometimes it is take a long time. But I trust. Already said, I trust the most powerful weapon which can change the world is human. So, and education anyway, the always there is we always working about that how we can evaluation of project. There is no consensus about the evaluation program. Each country has a different situation. The concern is give a time to change. So donor side, you usually do not waiting time. So we education of human resource, there is a small seed in his heart, his mind. Each seed had a different time to growing. So also we education human resource and make an effort to change the environment, push how we can change the environment to see the blooming. So that's we always approach multifactorial. That is inevitable. So that is why we are discussing here. Each have the different aspect, but all situation, multiple situation improved for blooming the human resource. Maximize for that is environment is very important. So, but I feel always there is a environment too bad to do acting some human resource activation. But we have never give up and keep in touch and make an effort to the environment for activation human resource. But always I feel the education of human resource is the most powerful weapon we can change the world. So sometimes it is there is no short-term result, positive result, but we always think about the long time. Sometimes there will be activation. So if the environment is better for activation human resource, so for that we have a multiple level we approach needed. So for that we discussing about that in here, how we can most activation the environment. So political aspect and bottom up, top down, also both sides activation is inevitable and essential part, I think. Not easy, but only we can discuss in academic society, we open discussion essential. And some successful case report is very informative for us. So for that aspect, for we more activation in academic society about the corruption, that is our purpose.
So it seems like we've reached the end of our discussion today. Thank you all, our panelists, for their insightful answers, and thank you to the audience for your participation. Today's discussion highlighted the challenges and next steps of corruption in global health. As we conclude, let's remember that the conversation does not end here. The challenges we've discussed today require ongoing collaboration and actions from all stakeholders. Thank you once again for your participation.